Hello, I'm Josh Carothers. I'm one of the joint replacement surgeons with the Christus St. Vincent's orthopedic team, and I'd like to talk to you today about hip and knee replacement. I will start with hip replacement. That is a treatment that we use to address the pain that's associated with advanced arthritis of the hip. That arthritis can arise as a result of various conditions, run-of-the-mill osteoarthritis, or also autoimmune diseases like rheumatoid arthritis or even post-traumatic conditions. But once it has progressed to the point that it is bone-on-bone arthritis, then hip replacement is the only way that we have of effectively treating that condition. So let me talk a little bit about the specifics of a hip replacement. This is a model of a hip with the thigh or the femur bone and then a portion of the pelvis which has the socket. This is a model of a hip replacement, so it actually shows the implants in place as opposed to all the bony anatomy. In my hands, the patient is positioned on their side. I make an incision just over the side of the hip, and then I enter the hip joint just behind the femur. We are able to get the hip out of place, and then while this is the replaced ball, we actually use a saw to remove the femoral head or the ball of the ball and socket joint. And then we address the native socket, and we prepare the inner surface of the socket, and then we place a metal socket which has a texture on it that your body will recognize, and the bone will actually grow into that texturing. But we place that socket into the hip like that, and then a plastic liner is placed into the socket, and that's the new socket of the ball and socket joint. And that works well because those parts don't have nerve endings, so they don't hurt when they rub together like the bones do. And then we go back to the femoral side, or the femur, and we place an implant, or prepare the femur for this implant, which has a very similar texturing on it, and we place that into your thigh bone. To that is attached a new ball, and that's your new ball and socket joint. The ball is made of ceramic, and so it actually is pink because of the processing they do, so you'll have a bright pink new femoral head, and that is the new ball and socket joint. Then we repair the soft tissues and close the wound. The procedure takes about an hour to do. Most patients we can let go home the same day, but for various reasons we may elect to keep some patients overnight for monitoring. There will be some discomfort. Some patients have more and some patients have less, but we will give you pain medication that you can use as needed to address the discomfort that you have. We want you to be active to the extent that your hip allows you. Early on, there may be some discomfort, and that usually gets better on a daily basis and allows you to do a little bit more every day. For my patients, I ask them to follow some rules after the hip replacement for the first 3 months. I ask that they not bend their hips more than about 90 degrees, and that comes into play getting in and out of a chair and getting in and out of the car. The reason for that is we want all of the tissues in the hip to heal up so that your body supports the hip over the long term. You'll see my assistant, Tyler, about a month after the surgery, and we'll get our first x-rays then. And then at 3 months, we talk about how those precautions relax and how to use the hip over the long term, the next 10 to 20 years. After the surgery, going forward, I like to see patients every 3 to 5 years to monitor the hip. We watch for any wear or tear that can occur slowly over time. Some of the issues at home that we want you to think about, and we will send you home with all these instructions, but we want you to monitor the incision and to please call us if there are any questions or concerns. So if the incision's looking red or there's any concerning drainage, we'd like you to call us at the office. Or if there are questions about the medications, we want you to call us as well. Tyler will go over all of that with you at his preoperative visit. With a knee replacement, it's the same philosophy, basically the same idea. I have a model here where the knee replacement has actually been done already, and obviously there are none of the soft tissues or the kneecap in place. But when we do a knee replacement, we will place you on the operating room table on your back, and we make an incision just in the front of the knee from about the top of the shin bone to just above the kneecap. And we'll move the kneecap over to the side. And when we do the surgery, we don't remove the entire knee joint. We really just remove the edges of the bone, about 1 centimeter on either side. And then we reshape the bone. So we make all these cuts to reshape the bone on the thigh bone or the femur side, and then on the top of the tibia or the shin bone. Once we've reshaped them, then we will place our new implants. And generally these are cemented in place. We use bone cement called polymethyl methacrylate, and that adheres the implant to the bone, and we use that both on the femur and the tibia. And then this plastic piece is inserted onto the plate of the tibia. That plastic piece will serve as your new, basically, articular cartilage. The reason that works so well is that none of these parts have nerve endings. So when they rub together and bear weight, you walk on it, you move, they don't hurt like the bone ends do. The surgery takes about an hour to do. We close everything up and put a dressing on, and then you'll roll to the recovery room and begin your recovery. Like a hip, it takes about an hour to do. Again, we let most patients go home the same day. But for various patients, we may elect to keep them in the hospital overnight just for monitoring. With a knee replacement, it's really important to be very aggressive with the physical therapy, working on getting the knee straight and getting it bent, especially during the first 4 to 6 weeks after the surgery. There will be some discomfort, and for that we will send you home with pain medication that you take as much or as little of as you need to be able to do the physical therapy. You'll increase your activity as the knee is feeling better, and so day by day you'll probably do a little bit more. But the knee is particularly sensitive, especially in the first couple of months. Even at 3 months, when patients are getting back to their routine activities, the knee can be sensitive and uncomfortable and even swollen at the end of the day. That will get better over the following 3 to 6 months. Over the last 15 years, generally over the course of my career, what we have gotten better at isn't the implants or the surgery itself, but rather the patient experience. We're much better with nerve blocks and using an array of medications to really address the discomfort that patients have, and that's one of the biggest advances that we've made as an orthopedic community. But I look forward to getting you taken care of, and thanks so much for choosing Chris at St. Vincent.